patients.
There are times when patients who present to an emergency department may require additional short-term monitoring in the hospital, but not formal admission to an inpatient unit.
This process, called observation, can be confusing for the patient. It may also have significant impact on out-of-pocket expenses.
On this week's Health Talk, a Norwalk hospital physician leader will walk us through how observation and admission decisions are made and what this means for patients and families.
So don't go away. We'll discuss this very important topic next. Hello, I'm Dr. Eric Mazer.
And I'm Dr. Andrea Peterson. Our topic is very important and not well understood amongst patients and the general public. We'll be discussing the designation of hospital patients as inpatient or observation status. This is an important distinction that can have significant impact for expenses. Joining us today is Dr. Seth Sullivan. He's a hospitalist clinician educator, and he helps run the hospital's utilization management committee.
Hello, Seth. A lot of introduction.
Hello.
But this is a really important topic, and I think so many people don't understand it out there. This is dictated to us by Medicare rules, so it's nothing that we as a hospital or as physicians
or a network or the
or
state.
Anyone really have a lot of discretion. But tell us, first of all, most people think when they go to the hospital and they stay overnight, they're in the hospital. But that's not true, is it?
Well, yeah, I guess it's literally true, but I guess in terms of how Medicare looks at the hospitalization, there are categories, a couple of different categories, I think, to start with, and for simplicity's sake, and that would be admission status versus observation status. The idea behind observation status on the part of Medicare is that there are patients who might require a short stay in the hospital for relatively simplistic care, such as IV fluids, monitoring to determine if there's any major organ dysfunction, in a patient who's at low risk, for example. And generally, these are going to be patients who are less complicated and stay for a short period of time. Contrasting that with admission status, who are sicker patients who may require more intense care.
No, I think Medicare defines this, and this is really hard because it puts a lot of pressure on the physician. If you expect your patient to require more than 2 midnights in the hospital, then they should go to the admission status, and if you think they can be let out more quickly, they should be admitted to observation status.
There's some general guidelines that we're asked to follow. Ultimately, Medicare does defer to the physician to make a decision per their guidelines. However, Medicare has offered, on the other hand, quite sort of specific criteria to consider when we are making that decision. One is whether or not the patient will stay for more than 2 nights, and if we anticipate that the patient is going to stay in the hospital for 2 nights of medically relevant care, then we should make that patient into an admission status as opposed to observation status. The other metrics that we look at are the intensity of service, in other words, how much we're providing to the patient, how intensive is the amount of the type of service we're providing, and as well as how sick the patient is.
And what the risk of something happening to that patient might be from a...
I didn't mean to interrupt you, I'm sorry, but yes, if the patient's at higher risk, that's absolutely something that we would consider.
Now, in most instances, is there a way a patient knows that their admission, whether they've been admitted or their observation? Maybe I know the answer, but patients may not know because you may be in a hospital bed in the middle of an inpatient unit and still be on observation status, right?
Yes, that's right. And so it's difficult to say based on geographical location or what's happening to you if you're in observation or admission status. The hospital does try to provide patients with that designation. However, I think there's some confusion around the terms, and when a patient is admitted, they're often sick or they're concerned about their health, or they're otherwise not able to necessarily process the distinction. There are multiple forms that have to be signed, and I think that this can get lost in the shuffle.
So how about their home status, if they come from a nursing home? Or they need more, does that determine admission versus observation?
Yes, it also, it does make a difference. Again, the major metrics we would look at are the anticipated length of stay, how sick the patient is, the risks to the patient, and the degree of service that we're providing to the patient. A very sick patient who requires simplistic care may still be appropriate for observation
that's something
status.
that I think really important to point out is that I remember once I was caring for somebody with gastric cancer who was dying and could take nothing in. And we brought him in the hospital and we gave him fluids for 48 hours or 72 hours till he perked up a little bit, and we sent the patient home, and Medicare denied the admission. And I remember thinking, well, how can, I was young then, how could Medicare deny this admission? This patient was dying. But as you said, the care was simple. and that was something that they would have said could have been done as an observation.
Yes, that's right.
Right. So, and maybe you can give our viewers a couple other examples, kind of concrete examples of patients who might qualify for observation status as opposed to inpatient status.
Sure. And so a scenario we run into pretty frequently is a patient who has chest pain. And so chest pain is a concerning symptom, as we know as physicians, and I'm sure as most of our audience knows. This can indicate severe diseases such as heart attacks. It can indicate diseases such as blood clot in the lung and multiple other medical emergencies. A vast percentage of patients are not going to have any of those symptoms. They may have a more straightforward, less life-threatening diagnosis, but most patients who have chest pain need to come to the hospital for at least a period of monitoring. In that circumstance, if the patient is at lower risk, stays for a night, is monitored, and perhaps undergoes some testing and is released perhaps the next day, that patient would be deemed most of the time to be appropriate for observation status because the patient was observed and found to have nothing wrong, they checked out well, and were discharged
I
after.
think, before we go further, this inpatient versus observation status really has great implications for the patient.
Yes.
I mean, because otherwise we're really talking about something that would be invisible. But in terms of payment, Medicare bases its payments and its nursing home decisions based upon this observation versus. Can you say a few words about that? Because I think this is really, really important for people at home to know so that they don't get trapped and suddenly say, well, I was here in the hospital for a week. Why can't I go to a nursing home? And it turns out they've been on observation.
Sure. So there's several rules that sort of are based upon the patient's status of observation versus admission. And one of them relates to nursing home stays. Typically, Medicare requires 3 nights in the hospital for what's called a qualified stay. That's a stay in which the doctors are actively performing treatment or diagnostic testing. And if you stay in the hospital for 3 nights, then you can be discharged to a nursing home and use your Medicare benefit. There are other implications as well.
But if you're in observation for 3 nights, that does not count.
Yeah, and sometimes you'll be in observation for a night and then switched over to admission status when diagnostic testing reveals that you're sicker perhaps than initially suspected. And so if you stay, for example, in observation for 1 night and then are converted to an admission status for the remaining 2 nights, you still would not necessarily be able to access that Medicare benefit.
So there's a patient sitting home, and even as a doctor wanting to do good for my patients, they say, well, why don't you just make it all inpatient, doc? I don't feel well. Why go through this rigmarole and put me at risk? That the other thing is, as an observation patient, it's treated as an outpatient by your insurance, and that means you have to pay co-pays, you have to pay for a lot of the laboratory testing. And this
Medicare would be 20%, I think.
Very different than inpatient stay. So, Doc, why don't you just make me an inpatient and let my insurance take care of it? Why don't you do that all the time?
Yeah, no, I think doctors would love to do that. We would love to have one category because what we do doesn't change. We are going to still run the same diagnostic tests. We're going to recommend the same therapy. Our decision to treat a patient based on their status is essentially non-existent. I can say with a lot of confidence, I've talked to a lot of doctors, your doctors, and I can almost say with 100% certainty that nobody is going to change their treatment plan based on the patient's status as assigned by the government or as assigned by Medicare. Unfortunately, the government has decided that there is a role for observation level care, that not every patient in the hospital requires what's called a DRG payment for an admission status. That stands for diagnostic related grouping. It gets to be a little bit complex and a little bit Byzantine, unfortunately. But the idea is that there are 2 separate pools of patients, those who are appropriate to be merely observed and treated, and those who require a full admission and payment to the hospital along the lines of a DRG.
And because Medicare has made that rule, it's a rule that hospitals and physicians must follow.
We must follow yes. I'm not sure exactly what the regulations stipulate. Sorry, I'm not an attorney, but I can say I'm almost certain that every hospital has to have a utilization process of some kind so that hospital services can be matched appropriately to the patient's needs. And the patient's needs currently are lumped into 2 buckets. That's observation versus admission.
So a hospital that has 100% admissions and no observations will be audited by the federal government. I think that's the point. And they will go to say, you overbilled for this, and you have to pay that back, and there's a penalty.
And there's penalties.
So
would be considered fraud.
For the viewers at home, they say it's a physician decision whether to make somebody observation or inpatient. But if you are not following their rules in making those decisions, the hospital is subject to fraud, paybacks, as well as a physician. So it's a tough role. You want to advocate for your patient,
Yes.
so that as much
Yes.
is paid for as possible, but if you don't play by the rules as Medicare defines them, everybody's subject to fines, and even worse. The other problem is that the rules themselves are not as black and white as you would like. And I think that's also the difficulty in managing this observation versus admission decision.
I think to Medicare credit, they do allow for physician judgment. I think there's an acknowledgement that only physicians can truly judge how sick a patient is, because they're the people at the bedside looking at the patient. As practicing clinicians, we can tell the audience that there's a lot of information you gather when you're at the bedside compared to just reading a chart. And so I think that correctly Medicare has said that the attending physician has the ultimate decision-making capacity. Unfortunately, as he said, there's this idea that patients need to be lumped into one of two categories, and that creates a lot of consternation, a lot of confusion.
We've been talking a lot about Medicare, but maybe you could speak to whether other insurance companies, commercial insurance companies, have adopted similar rules.
Yes. Now, insurance companies, of course, are a different matter. This is a private company that contracts with the hospital, and depending upon the contract between the hospital and the insurance company, there may be, there's typically some sort of a conversation between the insurance company and the attending physician and the hospital regarding the appropriate status. So the same idea applies. There's still an observation and admission status. The means of determining that can be a little bit different.
So just for our viewers' point of view, if they're not yet on Medicare, they may still be hearing these terms, observation.
So what should patients
They
do?
will be, yes.
What should the informed patient do in order to not get caught by surprise later on and not have a sudden big bill for what was outpatient therapy?
It can be very difficult, and it's not meant to be intentionally difficult for the patients to understand, but I think in point of practice it can be, because there's a lot of gray area between what can be an observation and an admission status. And so typically, if you need to, you can ask to speak with the utilization management team or the utilization review team, or you can ask your doctor, what is my status? Am I an observation patient? Am I an admission status? And at least determine what your correct status is going to be. Depending upon your type of primary insurance, your secondary insurance, your private insurance, there can be different financial problems imposed upon you. And unfortunately, there's no great way to tell what that's going to be. For example, a private insurance patient may actually owe the hospital less money if they're in observation status than if they're fully admitted. And so there's just a lot of confusion, unfortunately, around this whole process. It's confusing for the physicians oftentimes as well, unfortunately.
In the last minute, should patients who are undergoing elective surgery have these conversations with the team at their doctor's offices?
I think it's a great idea. I think it's a good idea to talk to the surgeon in the office. Oftentimes for surgical procedures, there's going to be a conversation between the surgeon's office and the coding team, and based on the type of procedure that's proposed, Medicare does have more sort of strict rules for what type of procedure is going to be undertaken. Surgery oftentimes is a clearer cut type of picture than the medical side of things. And it'd be a great question to ask your surgeon.
But it is important, and I say, especially with Medicare patients, I think they should ask and know what status they are and understand some of the reasons they were placed in that status. They may be able to appeal this at some time. I can tell you that we have appealed cases at the hospital level, and there are multiple levels of appeal that can take months to get to the final adjudication.
Oftentimes the hospital is going to be very interested in trying to get the patient, to advocate for the patient, and so very much the hospital does try to have the patient, well, first in the correct status. We do try to do things correctly based on current stipulations. If there's a gray area, we do try to generally have the patient considered to be a full inpatient admission.
And that's all we have time for. I think people should need to know about this observation versus inpatient. Be aware of it and question your doctor. Yes. So we're out of time for now. We'd like to thank our guest, Dr. Seth Sullivan, for joining us on Health Talk and discussing this very important topic.
Thank you.
Please send us any of your questions and comments to healthtalk@wchn.org. We'd love to hear from you.
Thanks for watching. Until next time, be well and try to stay out of the emergency room in the hospital.